Welcome back to Favaloro Foundation University Hospital. He's an 86 years old male presenting with the abdominal aortic aneurysm. He has history of hypertension as dyslipidemia and a very long time ago PCI. Next. So the ACG is under normal renal system with some negative tests in the lateral wall. The blood tests are normal. The body mass thickness is normal. He also has preserved left ventricular ejection fraction. And in the abdominal echo, it was shown an abdominal aortic aneurysm, which has grown in the past year more than 5 millimeters, reaching the 51. And that's why the patient was referred to us for treatment. Next. So this is the CT scan with 50 millimeters in diameter abdominal aortic aneurysm with a significant calcification in above the renals and also below the renals with a short neck. It's a little bit taper, but not too much with 16 millimeters length. This proximal neck of this bilobulate aneurysm, as you can observe on the right of your panel. Next. The significant calcification that we have also not only in the abdominal aorta, but also in both iliac arteries. So this is the proximal neck, 19 millimeters in diameter at the level of the renals and 22, 26 below the renals. So we are going to use a 26 device taking into account the renal diameter, where is also a significant calcification, as you can observe there. Almost 90 degrees of the circumference is calcified. So this is the right iliac artery with a diameter of 10 with a length of about 56 millimeters. So that's why we are going to use branches of 13 millimeters in diameter for both sides. And this is the left iliac artery with calcium at the ostium and also calcium and on the common, probably 90 degrees of calcification, with a diameter between 8.6 or 9 millimeters in diameter, and then the external is acceptable with 10 millimeters on the common femoral artery. We are going to use a percutaneous femoral access. We plan to use an ultra-low profile device for this patient. So that's why we are going to use this device, which is a 14 French device, which is a 3-modular design. It's an ultra-low profile. It's 14 or 16 French according to the main body diameter. In this case, with the 26, it's going to be 14 French. And for the left iliac branches, it's 12 French devices, hydrophilic coating. It's a PTFE graft. The stent is electropolished nitinol. Laser cut crowns with hooks for proximal fixation. So we have marks where the PTFE starts that we are going to see on fluoro. Other characteristics according to the diameter, a comparison with other devices. The tip capture mechanism, which is proximal, and I'm going to show you, allows us to open the body or the proximal part of the body. And when we are sure about the position, we can release the hooks. So this is a comparison where we are with this device in comparison with other devices, the old Zenith. Now the Alpha Zenith is lower profile also, the Endurance, the Excluder, and the Minos, which is probably one of the lowest profile device in the market, at least here in Argentina. Next, this is the configuration of the main body. The two branches, the main body has a length of 45 millimeters, the proximal part, and then both branches, the homolateral is 15 millimeters. All these marks, the proximal marks, which should be precisely below the renal ostium, and then the contralateral mark, which is a 7-shaped marker. Angio and echo guiding, we try to find the spot where we don't have calcium for doing a precise puncture there to have a proper sealing with the closure device. We also are using the cell navigator with the Angio CT. We introduce the ProStar once again because when we have such calcified common femoral arteries, we rather like to use this device. The overlapping of the fluoro and also the previous CT scan on the vessel navigator. There you can observe all the calcification that I was describing on the common iliac arteries, on the abdominal aortic, and also on the common femorals. And there we made a puncture below on the SFA, just to leave a wire there for protection for this biggest sheath. So we changed and we deployed there an thermohydrophilic wire leaving this terumo wire, which is outside here, below my hands for protection, just in case we have here. You can observe here, there's a terumo wire below the 11 French introducer sheath. So it's here. The puncture is exactly where my finger is here now, and it's catch against the skin to prevent any movement. And I'm going to leave this wire until the end of the procedure, just in case we have a complication. Then we have introduced two stiff wires that are side by side. And we have prepared for balloon predilatation and the common femoral artery. So now we are going to retrieve both balloons. I'm going to introduce the right coronary catheter just to mark the left renal artery. The performance of the device is okay. We still need some long-term follow-up. So once again, remember we have two wires there on the right of the aorta. One is the stiff wire, the amplas wire. We're going to introduce the device. And the other one is going to be left there outside the device. Remember, it's for protection of the introducer cells. So this is the introducer sheath from here to here. And then this is the commander. So we have here a security device that we have to push up. And then after that, we can clockwise here to release the main body of the device. When we get the position, we had to move this second security part of the device, and here is counterclock, and then pulling a little bit to release the hooks. And then when we finish the delivery of the body, we have to push here in this part of the device to retrieve the main body delivery and leaving the sheath in place where we will introduce the homolateral iliac branch. So here, one of the, we have two anatomical challenges. One is the proximal neck, calcified, little bit taper. You can observe how easily the device is advancing. We might have zoom now on the device, and we focus on the markers. So it's here. We have like an R configuration. This is orientation of the contralateral stump in posterior. If you rotate here like a 7, it's going to be on anterior. If we put here like a capital E, it's going to be on the lateral side of the delivery. So you can observe here this capital E. So the aorta has angulation. These markers where the tip of the right Shatkin catheter is positioned are the markers where we have, or actually the PTFE is starting. So PTFE is exactly below of the markers, on the lower limit of these dark markers. So we have the renal there. Yes. Okay, so it's almost in coincidence with the upper limit of the vertebra. Answer, Gustavo? So we are a little bit lower. We have to go exactly to the limit where the calcium is. Probably the calcium is the better marker. I will show you the calcium. This knot of calcium is probably the lower border of the renal artery. While I was advancing, I lost the orientation of the device. Once again, if you see here, it's now on again in a configuration of an R. I had to rotate counterclock to get the eye orientation again. I think the position is okay. I'm gonna move these markers up here, these markers, approximately, and then I want to start to release. I have to push a little bit. It's going to move forward a little bit. I have to keep the tension to see the orientation of the contralateral stump.
I think that the right catheter is a bit low.
Will you test? So probably it's a little low. So let me check. Fortunately, this catheter is losing the position. So I have to leave the markers here. So then I can pull a little bit. Because the marker is over the ostium, but remember the PTFE is starting below the markers. Test,
Ahí, de ahí.
test, Gustavo. So I think the position there is okay. Okay, I think it's okay there. Let's see next. Test. Okay, we can observe here the calcium. I'm going to release the last part. And now you see. No. Okay, let's do a final answer up. Okay. So left renal artery is okay. So the situation is okay. And now the contralateral stump is okay. Okay, Gustavo? No empujes, ¿eh? Okay. Suéltalo. And now, oh, it's okay. Now
You are going to release the free flow.
Yeah. I have to rotate this blue, unfortunately, here, holding the device. Yeah, now it's released. Perfect. And hydrophilic wire, so Erika is gonna go here.
This product is not also a low profile. You can navigate very well.
Yeah.
Isn't it? Tortuosity, short neck, angle.
I'm not sure if I am in. Hopefully,
I
yes.
think that it would be very useful for these difficult cases.
Yeah, I think we are in. Okay, excellent question. Which are the potential complications? First, vascular access is always a potential of complication because big sheath can always complicate. Okay, and this is number one. We can have bleeding. We might need, cover stent. We need surgical repair, retroperitoneal bleeding, and any other occlusion, late stenosis that we have some cases. This is a potential of complication.
Are you going to size?
Then the possibility of complication would be to have a type 1 endoleak. For type 1 endoleak, we have predictors. One is proximal neck, short necks, taper necks, angulating neck, heavily calcified. You are working inside an abdominal aortic aneurysm. You might have distal embolizations or abdominal embolizations. Renal failure. Of course, if you occlude the renal artery, it's a complication. You have to try to open it immediately. In this situation, it's important to use SIM catheters going from the top of the device or from the brachial access or radial access with a low profile catheter, trying to re-enter to the renal artery by side the device and to deploy the stent there to move the device to the true lumen and to release the ostium of the renal artery. What we are trying to do with Gustavo is to measure which is the distance from the device, which is here. And then we have 1, 2, 3, 4, 5, 7 centimeters. Which are the disadvantages of this device? We don't know exactly so far so many because it's a very new device for us. I think as many other devices, especially peripheral devices, when you decrease the profile, for sure you are decreasing the radial force. Retrieve the pigtail. And this is probably one. The second one is a long-term follow-up. Actually, it's not a limitation of the device. It's a limitation of the information. We still don't have it.
It's a very good device, and I think that we feel very comfortable with it.
So let me show you something. Let's go from below. So first, to be sure that we are on the area where we want to land, which is here, near the hypogastric artery. So in this situation, we can take out the the road mapping because interfere on the vision. Okay, we have a marker there. And then we have to see all the overlappings if they are okay. So they are okay. So once again, hold it here. So I'm gonna release here.
You rotate,
I'm
rotate
gonna
clockwise
soltar.
as the other one.
Okay, I'm gonna keep there, trying to keep these markers together. Fabian is watching the proximal marks. I am watching the distal mark, trying not to go too
low.
Too low, exactly. So now I can release the proximal part. Is that okay? So I can open here. So I can release there. Okay, everything is open. I'm going to advance the sheath. Now I have to disconnect here very smoothly. Okay, now I'm going to continue releasing the main body. Actually, the homolateral branch. Keep rotating. I'm going to release the homolateral branch, and it's totally free. Let's see, being very careful that the delivery system is coming in. Perfect. One is holding the sheath inside. So we have to use the Hercules balloon, not the regular Coda balloon, to go from this low profile sheath. So we are going to make an injection here or something. Little lower. So probably we should go, well, I think there is okay. Up? So we have 1, 2, 3, 4, 5, 6, 7 again. So the calculation done by the CT, hold it. It's okay. Once again, it's 13 by 100 millimeters. Anyway, remember, it's a 14 French sheath and a 12 French sheath. So what I have to show you here, that here we have some connector that should be exactly in the outer sheath to be, to be plugged, to be sure that we are working perfectly. Let me show you. So I'm pushing here. It is supposed to enter. It is supposed. Like now, I felt the click. It's okay. And now I have to advance everything together. I'm gonna release the security. Once again, I have overlapping of the markers and I am releasing. As you can observe, everything is moving out all together, the external sheath and the internal sheath. This marker should coincide with this. Is that okay? So at this, well, one of the limitation that we can add here is no so radio pack device. So probably should release the proximal part now, so preventing any movement. I'm going up. I'm going to inflate here on the proximal neck. Okay, no, just trying to see the rectangular configuration is more than enough.
You don't post delayed.
No, it's just to how to say, remodeling.
Remodeling.
Yes. Yeah, this is the word. So you see that it's conical. Will bet that you have a perfect ceiling and on the proximal edge. Here, where it was the stenosis, if we have resistance there, we can go with the
non-compliant balloon.
So I'm going to inflate there because if we still have a stenosis there, we also can deploy the stent. We still have some leakage there, but not so important. So I'm going to wait probably 30 days, get the patient back for CT. And if it is persistent, then we can deploy the a huge bare metal stent there. Okay, now let's go. Yes.
So I cannot see.
Yeah. 1, 2, 3, 4, 5, 6, 7, 8, 10.
10.
Perfect. And let's go with the 8 millimeter balloon from the other side. So I am using non-compliant balloons to produce a little bit bigger radial force in a very calcified arteries. I think it is showing that our, let's go there. Okay. It is perfect. Deflate the other balloon, deflate. We are going to use a syringe, a regular syringe, and we inflate with our hand. And we are trying to go at high pressure, trying not to damage the bifurcation of the device. So the proximal part is inside the main body, but not affecting. So here, when you have a proximal leakage, you might have to decide whether to put a cuff if the device is proximal, and the other possible solution, you should wait for some time, bring the patient back, and to decide. Much better. So Gustavo is going to remove the sheath. I'm going to close here.